Okay, so we'll start today's class. I will share my screen. Give me a moment. Once I share my screen, one of you can let me know if my screen is visible and if I'm audible. Okay. Nice. Is my screen visible and am I audible?
Yes, madam.
Yeah, okay. Okay. So we'll start today's session. Good evening, everyone. My name is Aishi, and this is the third week of the live sessions of host pathogen interaction. Basically, this is a course taken by course instructor Professor Himanshu Kumar from ISA Bhopal. And in these sessions, what we do, we discuss some previous year old assignment questions. We not only discuss the answer to those questions, we also discuss the concepts behind those questions so that it's easier for us to solve different types of other questions. Right? So we'll start today's session now. So we'll go to the first question for today, and we try to keep the sessions as interactive as possible. So in case you have a doubt, you can just type in the chat box, unmute and let me know. If I know the answer, I will tell you at the moment. If I don't, then you have to give me some time. I'll get back with the answer by next class. So for the first question for today is, which of the following is a bacterial infectious disease? Option A, chickenpox. Option B, tetanus. Option C, dengue fever. Option D, measles. And option E, mumps. So I'll wait for a few minutes if anybody wants to tell me the answer.
Option B, tetanus.
Okay. Anybody else? So yes, you're right. Option B, tetanus is the correct answer. Tetanus is caused by the bacterium Clostridium tetani. Okay, and the others are viral diseases. For example, chickenpox, I think, is caused by varicella zoster virus. Dengue fever by dengue virus, and measles and mumps by measles and mumps viruses. So the correct answer here will be tetanus. So first we'll talk a little bit about chickenpox. So we'll talk a little bit about all these diseases so that when you get questions related to the other diseases as well, you're able to answer. So chickenpox is basically a viral infection that is transmitted through the respiratory tract, right? It causes itching, skin rash, and small fluid-filled blisters. It is highly contagious and the symptoms usually disappear after 5 to 10 days. So, if you want to know about chickenpox in detail, you can read various papers out there. So, if you've seen, it's as I said, it's the mode of transmission is mostly airborne droplets like coughing, sneezing, and direct contact with fluid from chickenpox blisters and can spread 1 to 2 days before rash appears until all lesions crust over. Okay, the incubation period can be commonly mostly 14 days, around that. Symptoms will be the prodromal phase will be fever, fatigue, headache, loss of appetite. Then the rash phase, which is basically the hallmark of chickenpox. It's basically red spots, fluid-filled vesicles with the crust. Then lesions appear in different stages at the same time. It starts on face, trunk, spreads to whole body, intense itching. Then the pathogenesis, like what happens in the body, virus enters via respiratory tract, replicates in the lymph nodes, spreads through bloodstream like the viremia. It infects skin like characteristic vesicular rash. Now the virus becomes latent in sensory nerve ganglia and it can reactivate later as shingles like herpes zoster. Now, what are the complications which are more common in adults, pregnant women, and immunocompromised individuals? There can be a secondary bacterial skin infection, can lead to pneumonia, encephalitis, congenital varicella syndrome if infected during pregnancy. Now, what are the prevention mechanisms? Obviously, live attenuated varicella vaccine, usually given in 2 doses, provides long-term protection. Treatment is mostly supportive care like antipyretics, antihistamines for itching, acyclovir in severe cases of high-risk individuals. Immunity infection usually gives lifelong immunity. That's why you would have heard that someone who has chickenpox once, they generally don't get it again, right? So this is the varicella zoster virus that causes chickenpox. Okay, what are the predisposing factors of chickenpox? Not taking the chickenpox vaccine, not having chickenpox before, diseases that lower the immune system such as cancer, and using of immunosuppressive drugs, right? So, who are the high risk groups? Teenagers, pregnant women, newborns, immunocompromised patients, or the elderly. So, what are the modes of transmission? Generally, it spreads easily through airborne respiratory droplets during coughing or sneezing from an infected person to a healthy person. It spreads from one person to another through direct or indirect contact with skin rash. As I said, the symptoms will be 10 to 21 days after viral infection. Now, skin rash is the main clinical symptom of chickenpox. Symptoms last for 5 to 10 days, and other symptoms which could develop 1 to 2 days before skin rash include fatigue, headache, loss of appetite, and fever. Most cases of chickenpox initially develop on face, chest, and back. After that, it spreads to other parts of the body. Like chickenpox rash passes through 3 stages. The first stage will be formation of pink or red blisters, that is the papules. Then the second stage will be formation of blisters filled with small amount of fluid vesicles within 1 day. Later it ruptures and fluid leaks. And third stage is crosses over the ruptured blisters that require multiple days to disappear. So generally doctors diagnose chickenpox by identifying the skin rash, which is a physical examination, right? And if there is some doubt about the diagnosis, infection can be confirmed through laboratory investigation like blood test or lab examination of blister fluids to detect the virus. These are the complications that I told you about. Sometimes it can lead to encephalitis like brain infection, bacterial infection in skin, bones and joints, pneumonia which is lung infection, septicemia which is blood infection. The best prevention against chickenpox is vaccination if you haven't been infected with chickenpox before, right? And the vaccine is safe and effective that most of those who are vaccinated will never get chickenpox again. In case of reinfection, the vaccine contributes to reducing the severity of symptoms and become limited to few red spots as well as low-grade fever or no fever at all. When should you visit the doctor? When the rash spreads to one or both the eyes, when you experience swelling, redness of the skin, rash which suggests a secondary bacterial infection, or when skin rash is accompanied by other symptoms such as tachycardia, severe cough, vomiting, neck stiffness, or high grade fever. Now, what are the treatments? Sometimes the doctor may prescribe antihistamines to relieve itching. So, also the doctor may prescribe antiviral medications to the patients who are at a greater risk to develop complications, right? So, this will help in shortening the duration of infection as well as reducing the risk of complications. So, what are lifestyle modifications and home remedies? You can follow like self-care measures at home only. Relieve chickenpox symptoms. Avoid skin scratching. I understand the skin will be itching a lot, but you have to avoid scratching of skin. Use hand gloves, especially at night and while trimming nails. Relieving and itching and other symptoms, take a shower with cold water mixed with baking soda or sodium bicarbonate or oatmeal, which should be soaked up in lukewarm water for a few minutes until the milky liquid comes out, which in turn might relieve itching. Okay, so the best prevention against chickenpox is obviously vaccination. First dose of the chickenpox vaccine is varicella 1 given at 12 months. Second dose is given at 5 to 6 years of age. Next we move on to tetanus. Tetanus, if you want to know detailed review on tetanus, we can talk about tetanus right now. Tetanus is a acute, often fatal disease caused by an exotoxin produced by the bacterium Clostridium tetani, but prevented by immunization with tetanus toxoid. It is characterized by generalized rigidity and convulsive spasms of skeletal muscles. The muscle stiffness usually involves the jaw, the locked jaw, and the neck, and then becomes generalized. Okay. The Clostridium tetani is a gram-positive anaerobic spore-forming bacillus. Like these spores are extremely resistant. They are found in soil, dust, animal feces, etc. So they can grow in anaerobic conditions like deep wounds, necrotic tissue. Now, the mode of transmission is not from person to person. Spores enter through punctured wounds, cuts, burns, contaminated needles, umbilical stump, that's neonatal tetanus, and the incubation period can be 3 to 21 days. Shorter incubation can lead to more severe diseases. So what happens, the spores enter the wound, germinate under the anaerobic conditions. Bacteria can produce tetanospasmin, which is a neurotoxin. Toxin travels via retrograde axonal transport to the central nervous system, and it blocks release of inhibitory neurotransmitters like glycine or GABA transmitter. Result is uncontrolled muscle contraction or spastic paralysis. The clinical features of the early signs can be trismus, which is locked jaw, neck stiffness, difficulty swallowing. Progressive signs are generalized muscle rigidity, painful spasms triggered by light, sound and touch, opisthotonus, like arched back, and respiratory muscle involvement is respiratory failure. The types of tetanus can be generalized tetanus is most common, then localized tetanus, then cephalic tetanus and neonatal tetanus. Due to unclean umbilical cord practices. The diagnosis can be clinical diagnosis, no reliable lab test, so history of wound plus characteristic symptoms. Treatment can be to neutralize the toxin like human tetanus immunoglobulin, then control infection like with metronidazole or penicillin, control muscle spasms using benzodiazepines. Supportive care will be airway management, mechanical ventilation if needed. Prevention, which is most important, will be tetanus toxoid vaccine like the DPT, diphtheria, pertussis, tetanus. Booster doses given every 10 years and proper wound care, clean delivery practices, all of these. So, natural infection does not give immunity. Vaccination is essential even after recovery, right? So, that's why when you cut yourself using a rusted surface like maybe sometimes knife, sometimes any kind of steel surfaces in a construction site, or maybe if you get burns, very dangerous burns, you are given the tetanus, right? That's because of this infection which may happen. So it was first described in Egypt over 3000 years ago, and it was again described by Hippocrates. So basically, they noticed tetanus in animals by injecting them with pus from a fatal human tetanus case. Okay, and during the same year, Nicolai produced tetanus in animals by injecting them with samples of soil. Then again, Ketas had to isolate the organism from a human victim, showed that it produced disease when injected into animals, and reported that the toxin could be neutralized by specific antibodies. Then Nokar demonstrated the protective effect of passively transferred antitoxin and passive immunization in humans. Okay, and passive immunization and prophylaxis for tetanus during World War I, and tetanus toxoid was first widely used during World War II. So you have to appreciate the vaccines that we use today have been developed with the help of so many people and so many patients. It directly or indirectly, intentionally or unintentionally contributed to the development of these vaccines, right? Tetanus is basically a major health problem in the developing world and is still encountered in developed world. There are between 800,000 to 1 million deaths due to tetanus each year. Okay, and mostly they can occur in Africa or Southeast Asia, right? So this is the acridine orange stain of characteristic Clostridium tetani with endospores wider than the characteristic drumstick shape. Okay. So it's a slender, as I said, gram-positive anaerobic rod that may develop a terminal spore, giving it a drumstick appearance. The organism is sensitive to heat and cannot survive in the presence of oxygen. The spores, in contrast, are very resistant to heat and the usual antiseptics. They cannot survive autoclaving at this temperature for 20 minutes. And the spores are also relatively resistant to phenol and other chemical agents. The spores are widely distributed in soil and in intestines and feces of horses, sheep, cattle, dogs, rats, cats, guinea pigs, and chickens. Many test-treated soil may contain large numbers of spores, and spores may persist for months to years. So, tetany produces two exotoxins, titanolysin and titanospasmin. And the function of titanolysin is not known with certainty. Titanospasmin is a neurotoxin and causes the clinical manifestations of tetanus. Titanospasmin estimated human lethal dose is something around 2.5 nanogram per kg. Tetanus occurs worldwide but is most frequently encountered in densely populated regions in hot, damp climates with soils rich in organic matter. Okay, and organisms are primarily found in the soil and intestinal tracts of animals and humans. The mode of transmission is primarily by contaminated wounds, tissue injury, deep puncture wounds, crushed wounds, etc. Tetanus is not contagious from person to person, so it's the only vaccine preventable disease, infectious, but still not contagious, right? So anaerobic conditions basically allow germination of spores and production of toxins, and toxin binds in central nervous system, interferes with neurotransmitter release to block inhibitor muscles impulses, and leads to unopposed muscle contraction and spasm. Okay, what are the confirmatory features like rhizus sardonicus or fixed near lockjaw opisthotonus? I'm not sure about the pronunciation. Basically, which means extension of lower extremities, like flexion of upper extremities and arching of the back. So the examiner's hand can be passed under the back of the patient when he lies on the bed in supine position. Then neck rigidity. So these are the types of tetanus. This is very much in detail, right? Traumatic tetanus, puerperal tetanus, otogenic tetanus, etc. So, local tetanus is an uncommon form of the disease in which patients have persistent contraction of muscles in the same anatomic area as the injury. Local tetanus may precede the onset of generalized tetanus but is generally milder. Only about 1% of cases are fatal. Syphilic tetanus is a rare form of the disease, occasionally occurring with otitis media, like ear infections, in which C. tetani is present in the flora of the middle ear or following injuries to the head. There is involvement of the cranial nerves, especially in the facial area. The most common type, about 80% of the reported tetanus, is generalized tetanus. The disease usually presents with a descending pattern. So the three objectives of management tetanus: to provide supportive care until the tetanus has been, that is fixed tissue, has been metabolized, to neutralize the circulating toxin, to remove the source of tetanospasmin. Okay. So these spores are extremely stable. Although immersion in boiling water for 15 minutes kills most spores, exposure to saturated steam under 15 lbs of pressure for 15-20 minutes in 121 degrees Celsius is highly effective against spores, and sterilization by dry heat is lower than by moist heat, but it is also effective against spores. Xylene oxide sterilization is also sporocidal. Okay. As I said, tetanus toxoid was developed in 1924 around and were widely used during World War II. They basically consist of a formaldehyde treated toxin, right? And there are two types of toxoid available: adsorbed aluminum soil precipitated toxoid and fluid toxoid. So although the rates of seroconversion are about equal, the absorbed toxoid is preferred because the antitoxin response reaches higher titers and is longer lasting than that following the fluid toxoid. So these are two types of toxoids which are available for vaccination, right? But it has been seen in experiments. There is someone who was not muted. Yeah. Yeah. So it has been seen that the adsorbed toxoid is preferred because the response of this toxoid reaches high titers. Okay. in the body, and also it is more long lasting. So how is it done? It's a very short gist that it's basically in an isotonic sodium chloride solution containing sodium phosphate buffer to control the pH. The vaccine after shaking is a turbid liquid whitish green color. So the culture is grown in a peptone based medium and detoxified with formaldehyde. Then the detoxified material is then purified by serial ammonium sulfate fractionation followed by sterile filtration, and the toxin is adsorbed to aluminum potassium sulfate, and the adsorbed oxide is diluted with a physiological saline solution and thimerosal as added to the final concentration. So these are the how this is how it basically it is made. We will not go into too much detail of neonatal tetanus. We don't need to. So basically in gist, it is a highly acute fatal wound infection toxemic disease of all animals and human, which is caused by toxins of Clostridium tetani and characterized by an increased reflex excitability of the motor nerve centers with continuous spasmodic contraction of all striated muscles and clinically by hyperesthesia, tetany, convulsion and death. Okay. So basically it is interesting appearance anaerobe or we have seen. It produces a number of toxins, among them and the most important are neurotoxin or tetanus plasmin, as we said. It's a protein in nature and is responsible for characteristic signs of tetanus. Then also hemolysin or tetanolysis is basically a potent lethal toxin. It's responsible for the hemolysis around colonies on blood agar. So it grows on blood agar producing colonies. It basically degrades blood agar. You can understand the effect it has on blood. Producing colonies surrounded by complete zones of hemolysis after 24 to 48 hours. So these spores can be killed by direct sunlight within 12 days, boiling water, 30% hydrogen peroxide within 10 minutes. Okay. We don't need too much. So the spores of C. tetanus are unable to grow in normal tissue or even in bones if the tissue remains with the oxidation reduction potential or the circulating blood. Suitable conditions for multiplication occur. The bacteria remain localized in the necrotic tissue at the original site of infection and multiply. As bacterial cells undergo proteolysis, the potent neurotoxin is released, and the neurotoxin is absorbed by the motor nerves in the area and passes up the nerve thread to the spinal cord, where it causes ascending tetanus. Now, the toxin causes spasmodic tonic contractions of the voluntary muscles by interfering with the release of neurotransmitters from presynaptic nerve endings. Now, the excess is carried off by the lymph to the bloodstream and thus to the CNS, where it causes descending tetanus. Now, spasms affecting the larynx, diaphragm, and the intercostal muscles lead to respiratory failure. An involvement of the autonomic nervous system results in cardiac arrhythmias, tachycardia, and hypertension. Okay. So, we'll not go into too much detail about the clinical signs. You already know about tetanus. Now, what is the measles and the measles vaccine? It's a highly contagious viral illness, first in the 7th century, and near universal infection of childhood in pre-vaccination era, and it's frequent and often fatal in developing areas. It's a paramyxo virus, like. So, if you want to know about the measles virus in detail, it's a paramyxo virus and an RNA virus, and it's a one antigenic type. Hemagglutinin important surface antigen rapidly inactivated by heat and light. Okay. So, measles virus is rubella. It's basically a highly contagious viral disease caused by the measles virus. The family is Paramyxoviridae. Genus is Morbillivirus. It's an enveloped single-stranded negative strand sense RNA virus. It has hemagglutinin and fusion proteins that cause syncytium formation. So, what are the modes of transmission? Airborne droplets like aerosol, extremely contagious. Virus can remain viable in air for up to 2 hours. Incubation period will be around 10 days. Now, virus enters via respiratory tract, replicates in local lymphoid tissue, causes primary viremia. It can disseminate to skin, conjunctiva, respiratory tract, and causes immunosuppression by infecting immune cells, increased risk of secondary infections. The prodromal phase will be cough, coryza, conjunctivitis, fever. The pathognomic sign will be complex spots like bluish white spots on buccal mucosa appear before rash. The rash phase will be maculopapular rash, starts on face, behind ears, spreads downward. And rash can fade in the same order. Complications will be otitis media, pneumonia, diarrhea, acute encephalitis, vitamin A deficiency. Okay, and diagnosis basically confirmed by the measles specific IgM antibodies like RT-PCR. Is in the process of RT-PCR. Treatment will be no specific antiviral, supportive care, and vitamin A supplementation. Prevention can be live attenuated vaccine given as MMR, measles, mumps, rubella. Two doses might give you lifelong immunity. Okay. So it's a respiratory transmission of virus, as I said, replication in narrow nasopharynx and regional lymph nodes, primary viremia for 2 to 3 days after exposure, and secondary viremia for 5 to 7 days after exposure. It spread to tissues. Stepwise increase in fever to 103 Fahrenheit or higher. Incubation period 10 to 12 days. Condition will be diarrhea, otitis media, pneumonia, encephalitis, death, hospitalization. So, isolation of measles virus from a clinical specimen like nasopharynx or urine. Significant rise in measles IgG, immunoglobulin G by any standard serological assay. We'll talk about EIA or ELISA in the next question, so I'm not explaining it here. And positive serological test for measles IgM antibody. Okay, the reservoir will be human, transmission can be respiratory, airborne. Temporal pattern is peak in late winter and spring, and communicability is like 4 days before or 2 after 4 days rash on state. So, what are the measles vaccine? The composition will be measles by live virus, efficacy 95%, duration of immunity lifelong, and scheduled 2 doses. It is scheduled should be administered with mumps and rubella as MMR, measles, mumps, and rubella. So, measles or lack of immunity in previously vaccinated persons, so 2 to 5% recipients do not respond to the first dose caused by antibody damaged vaccine record errors. Most persons with vaccine failure will come there for the second dose. Now, all infants greater than 12 months of age and susceptible adolescents and adults without documented evidence of immunity. So, 12 months is the recommended and minimum age. MMR given before 12 months should not be counted as a valid dose. Revaccinate at greater than 12 months of age. Now, the second dose is intended to produce measles immunity in persons who fail to respond to the first dose, like primary vaccine failure. That may boost immunity titers in some, antibody titers in some person. Second dose is of MMR is at 4 to 6 years. Second dose may be given at any time greater than 4 weeks after the first dose. All states ensure that 2 doses of MMR are required for school entry, and all children in kindergarten through grade 12 have 2 doses of MMR by all this. Okay. There is serological evidence of immunity and documentation of receipt of measles containing virus. So, severe allergic reaction to the prior dose or vaccine component, pregnancy, all of these are MMR vaccine contraindications, and precautions, immunosuppression or moderate or severe acute illness, recent blood products. So, measles and mumps viruses grown in chick embryo fibroblast culture. Studies have demonstrated safety of MMR in egg allergic children vaccinated without testing. So, MMR recommended for persons with asymptomatic and mildly symptomatic HIV infection as well. It's not recommended for those with evidence of severe immunosuppression. And pre-vaccination HIV testing not recommended. So coming back to the question that we started with today, which of the following is a bacterial infectious disease? And you were right. The correct answer was tetanus. I'll wait for a few minutes, taking a break. If anyone has any questions, you can ask me now by typing in the chat box or saying, and then we'll move on to the next question for today. Anybody has any questions? Okay, then we will move on to the next question for today. If nobody has any doubt in this question. So the next question for today is, which is the function of the spleen? Sorry. What is the function of the spleen in the immune system? Your options are A. Blood filtration and protection. B. Digestion of nutrients. C. Oxygen exchange. D. Hormone production. E. Muscle coordination.
Blood filtration and production.
Sorry.
Option A, blood filtration and production.
Okay, anybody else? Yes, so the correct answer will be blood filtration and protection. The spleen filters the blood, removing old and damaged red blood cells. It plays a key role in immune defense by trapping the blood-borne pathogens, activating lymphocytes, B and T cells, producing antibodies, especially IgM. Okay. Other options are incorrect because digestion of nutrients will be intestine, oxygen exchange will be lungs, hormone production will be endocrine glands, and muscle coordination will be cerebellum. So as I said, the immune system is a barrier to the pathogens. Our immune system is made up of both individual cells and proteins, as well as entire organs and organ systems that defends the body against infection. So the organs of the immune system include the skin and the mucous membranes, and the organs of the lymphatic system too. So normally the immune system is composed of primary or central and secondary or peripheral organs. And this keeps a record of every germ microbe it has ever defeated, so that it can recognize and destroy the microbe quickly if it enters the body again. So abnormalities of the immune system can lead to allergic diseases, immunodeficiencies, and autoimmune disorders. So the main parts of the immune system are bone marrow, thymus, spleen, white blood cells, antibodies, complement system, and the lymphatic system. So the lymphatic system is a network of delicate tubes throughout the body. The main roles of the lymphatic system are to manage the fluid levels in the body, react to the bacteria, deal with cancer cells, deal with cell products that otherwise would result in disease or disorders, and absorb some of the fats in our diet from the intestine. Now, the lymphatic system is made up of lymph nodes, which is also called lymph glands, which trap microbes, lymph vessels, tubes that carry the lymph, the colorless fluid that guides the body's tissues and contains infection-fighting white blood cells, the lymphocytes, which are white blood cells, spleen, bone marrow, and the thymus. Now, the primary lymphoid organs, these organs include the bone marrow and the thymus. The primary organs enable the performance of functions of the cell and the immune regulation. And the bone marrow is a primary immune organ and the source of all cell lines used by the immune system and the place of B cell maturation. Whereas the thymus is a primary immune organ in which thymocytes are differentiated into T cells and a variety of immunoregulatory substances are produced. So they are both special immune system of cells called lymphocytes, and the secondary lymphoid organs will be, these organs include the lymph nodes, the spleen, the tonsils, and certain tissues in the various mucous membrane layers in the body. For instance, in the bowel. So they are these organs where the cells of the immune system do their actual job of fighting off germs and foreign substances. So the primary lymphoid organs will be like bone marrow. Bone marrow is a sponge-like tissue. One second. It is a sponge-like tissue found inside the bones where most immune system cells are produced, and then also multiply. These cells move to the other organs and tissues through the blood. So the bone marrow's pluripotent stem cells can be differentiated into a variety of cell types like lymphoid stem cell. The blood vessels of the bone marrow create a blood marrow barrier which inhibits immature cells from leaving the bone marrow. Now, there are two types of bone marrow: red marrow, which is made up of hematopoietic tissues, including cells of the immune system, and the yellow marrow, which consists of fat cells. At birth, many bones contain red bone marrow, which actively creates immune system cells. Over the course of our life, more and more red bone marrow turns into fatty tissue. In adulthood, only a few of our bones still contain red bone marrow, including the ribs and breastbone and the pelvis. From the clinical point of view, the bone marrow is the most important object for transplantation in children with primary immunodeficiencies. So, biopsies of the bone marrow widely used for diagnostic purposes in hematology. Sorry. So the thymus is located behind the breastbone above the heart. This gland-like organ reaches full maturity only in children and is then slowly transformed to fatty tissue. So special types of immune system cells called thymus cell lymphocytes like T cells mature in the thymus, and these cells coordinate the processes of the innate and the adaptive immune system. And T cells move through the body and constantly monitor the surfaces of all cells for changes. So, thymus consists of capsule-coated lobules containing the strictly isolated parenchyma and the future T cells, thymocytes, which may pass through the vessel endothelium here. So there are three parenchymal zones of the thymus: subcapsular, cortical, and medullary, that accord with major stages of T cell lymphopoiesis, right? And the cortical and the thymus produces numerous hormones, neurotransmitters, and molecules of the immune system. So, from the clinical point of view, a thymectomy performed in adults does not lead to any immunodeficiency. So, the secondary lymphoid organs are lymph nodes, which are small vein-shaped tissues found along the lymphatic vessels. They act as filters. Various immune system cells trap germs in the lymph nodes and activate the creation of special antibodies in the blood. Swollen or painful lymph nodes are a sign that the immune system is active, for example, to fight an infection. Each lymph node is divided into lymph nodules, which contain a cortical zone of primary follicles with B cells, a paracortical zone of T cells, and a basal part of the nodule in the medulla. The lymph nodes are among the secondary organs of the immune system, widely present in many parts of the body, and have an artery, vein, and afferent and efferent lymphatic vessels. The afferent lymphatics are multiple and wider than efferent vessels, so cells molecules can easily enter the lymph nodes. So conversely, the passage of large cells like macrophages through the afferent vessels is difficult, so that they remain to function within the lymph node. From the clinical point of view, the lymph nodes have essential clinical significance. They may be enlarged, swollen, and inflamed in many infections, tumors, and even under some non-infectious conditions. So the palpation of accessible lymph nodes serves as a suitable means of monitoring for any physician. Now the spleen. Spleen is one of the secondary organs of the immune system that function at the systemic level when antigens enter the blood. Thus, the spleen is important in fighting the infections that have invaded the blood. And the spleen is located in the left upper abdomen beneath the diaphragm and is responsible for different kinds of jobs, like it stores various immune system cells. When needed, they move through the blood to other organs. Now, scavenger cells or phagocytes in the spleen act as a filter for germs that get into the bloodstream. It breaks down old or damaged red blood cells like erythrocytes, stores and breaks down platelets like thrombocytes, It also makes disease-fighting components of the immune system, including antibodies and lymphocytes. The spleen consists of a red pulp and white pulp. The red pulp plays a role in blood clearance, removing old erythrocytes, maintaining an additional reservoir of blood, and metabolizing hemoglobin. So the white pulp is composed of lymphoid follicles rich in B cells, the marginal zones rich in B cells, and periarteriolar lymphoid sheaths rich in T cells, and the white pulp is vital for the immune processes, including B cell mediated responses, synthesis of antibodies, removal of antibody coated microbes, production of properdin, and storage of monocytes. So, properdin is a protein present in the blood involved in the body's response to certain kinds of infection. So, from the clinical point of view, a splenectomy or spleen removal leads to a significant increase in the usual death rate from the pneumonia and a much diminished frequency of memory B cells. If splenectomy is planned, vaccination against pneumococci must be performed. There is always a lot of blood flowing through the spleen tissue. At the same time, this tissue is very soft, right? In the event of severe injury, for example, in an accident, the spleen may rupture easily. Surgery is then usually necessary because otherwise there is a danger of bleeding to death. So if the spleen needs to be removed completely, other immune system organs can carry out its roles. Then we have tonsils. The tonsils are also secondary organs of the immune system part because of their location at the throat and palate. They can stop germs entering the body through the mouth or the nose. And the tonsils can also contain a lot of white blood cells which are responsible for killing germs. So there is also lymphatic tissue on the sides of the throat which can perform the functions of the palatine tonsils if they are removed. Mucous membranes, like the bowel, plays a central role in defending the body against germs. More than half of all the body cells that produce antibodies are found in the bowel wall, especially in the last part of the small intestine and in the appendix. And these cells detect the foreign substances and then mark and destroy them. They also have save information about substances in order to be able to react more quickly the next time. The large intestine also contains harmless bacteria called gastrointestinal tract or gastrointestinal gut flora. So healthy gut flora make it difficult for germs to spread and enter the body. And mucous membranes support the immune system in other parts of the body too, such as the respiratory and urinary tracts and the lining of the vagina. Like the immune system cells are directly beneath the mucous membranes, right? Where they prevent bacteria and the viruses from attaching. And the skin and the mucous membranes are the first line of defense against germs entering from outside the body. They act as a physical barrier with support from different substances such as antibacterial substances which can kill germs right from the start. Now there is certain enzyme, I think you have heard the name, the lysozyme, found in the saliva, the airways and even the tear fluid. And it destroys the cell walls of bacteria. So the mucus in the bronchi helps trap many of the germs we breathe in. So they can be moved out of the airways by the hair-like structures, the cilia. So stomach acid stops most of the germs that enter the body in the food we eat. And harmless bacteria on our skin and many of the mucous membranes in our body also act as part of the immune system. In addition, the reflexes that cause us to cough and sneeze help us to free our airway of germs. So that's the immune system. These cells are the white blood cells in the human bloodstream, lymphocytes and monocytes or granulocytes, and the polymorphonuclear leukocytes or granulocytes which are present in the common blood test. Now, they are the key players in the immune system. They are made in the bone marrow and are part of the lymphatic system. Now, white blood cells move through the blood and tissue throughout the body. looking for foreign invaders or microbes such as bacteria, viruses, parasites, and fungi. When they find them, they launch an immune attack. Now, T lymphocytes and B lymphocytes are the main cells of the adaptive immune responses, whereas innate lymphoid cells are important for innate immunity and have important functions in innate immune responses to the infectious microorganisms and in the regulation of the homeostasis and inflammation. ILCs are primarily tissue resident cells found in both the lymphoid and non-lymphoid tissues and rarely in the peripheral blood. They are particularly abundant at mucosal surfaces, playing a key role in mucosal immunity. One second. So then, if we come to the antibodies, antibodies help the body to fight microbes or the toxins, poisons that they produce. They do this by recognizing substances called antigens on the surface of the microbe and in the chemicals they produce, which mark the microbe or toxin as being foreign. Antibodies then mark these antigens for destruction, and there are many cells, proteins, and chemicals involved in this attack. The complement system is made up of proteins whose actions complement the work done by antibodies, right? So, as well as the immune system, the body has several other ways to defend itself against microbes. Barriers that keep out pathogens are the body's first line of defense. The body's most important non-specific defense is the skin, which acts as a physical barrier to keep pathogens out. Even openings in the skin, such as mouth and the eyes, are protected by saliva, mucus, and tears, which contain an enzyme that breaks down bacterial cell walls. The first line of defense includes mechanical, chemical, and biological barriers. Mechanical barriers. Mechanical barriers physically block pathogens from entering the body. The skin is the most important mechanical barrier. In fact, it is the single most important defense of the body. Outer layer of the skin is tough and very difficult for pathogens to penetrate. Now, mucous membranes provide a mechanical barrier at body openings. They also line the respiratory, GI, urinary, and reproductive tracts. The mucous membranes secrete mucus, a slimy substance that traps pathogens, and the membranes also have hair-like cilia. So the cilia sweep mucus and pathogens towards the body openings, where they can be removed from the body. Now, when you sneeze or cough, pathogens are removed from the nose and the throat, and tears wash pathogens from the eyes, and urine flushes pathogens out of the urinary tract. Now, if we talk about the chemical barriers, they destroy pathogens on the outer body surface at body openings and on inner body linings. So, sweat, mucus, tears, and saliva all contain enzymes that kill pathogens. So, urine is too acidic for many pathogens, right? And semen contains zinc, which most pathogens cannot tolerate. In addition, stomach acid kills pathogens that enter the GI tract in food or water. Now, if we talk about the biological barriers are living organisms that help protect the body. Millions of harmless bacteria live on the human skin. Many more live in the GI tract. The harmless bacteria use up food and space, so harmful bacteria cannot grow. Now, the second line of defense is if a pathogen does make it into the body, there are secondary non-specific defenses that take place. The skin, it is a waterproof barrier that secretes oil with bacteria killing properties. The lungs, which is the mucus phlegm cilia wave. The digestive tract, the mucus lining containing antibiotics, acid in the stomach can kill most microbes. Other differences like body fluids like skin, oil, saliva, and tears contain antibacterial enzymes that help reduce the risk of infection, and the constant flushing of the urinary tract and the bowel also help. So fever is an immune system response. A rise in the body temperature or fever can happen with some infections. Fever also triggers the body's repair process. Now, the immune system and the microbial infection. The immune system keeps a record of every microbe it has ever defeated in types of white blood cells, B and T lymphocytes known as memory cells. This means it can recognize and destroy the microbes quickly if it enters the body again before it can multiply and make you feel sick. Some infections like the flu and the common cold have to be fought many times because so many different viruses or strains of the same type of virus can cause these illnesses. However, catching a cold or flu from one virus does not give you immunity against the others. We don't need to do all this. So, Chinese it derives most of its blood from the splenic artery, small amount from short gastric vesicles, and venous drainage is splenic vein. So, total splenic inflow of blood is approximately 250 to 300 ml per minute. So, physiologically, the roles are filtration, hose defense, storage, and hematopoiesis. So, complete absence is rare, associated with other congenital abnormalities such as situs inversus and cardiac malformations. Hypoplasia more common finding. Accessory spleens like are common, generally situated in the gastrosplenic ligament or the tail of the pancreas, omentum or mesenteries of the small or large intestine. So in splenectomy, if an accessory spleen is overlooked, the benefit of removal of the definitive spleen can be lost. Splenomegaly means enlargement of spleen. Normal spleen not palpable has to enlarge 2 times to be detectable. Enlarges from left hypochondrium to right iliac fossa. Okay. Now basic splenomegaly is used due to increased function abnormal blood flow infiltration. The removal of defective RBCs like spherocytosis, thalassemia, hemoglobinopathies, nutritional anemias, early sickle cell anemia, and increased functional immune hypertension like response to immune infection like viral, bacterial, fungal, and parasitic, mononucleosis, AIDS, viral hepatitis, subacute bacterial endocarditis, bacterial septicemia, splenic abscess, typhoid fever, brucellosis, leptospirosis, tuberculosis, histoplasmosis, malaria, leishmaniasis, trypanosomiasis. It can be disordered immune regulation, rheumatoid arthritis, which is an autoimmune disorder, systemic lupus erythematosus, serum sickness, autoimmune hemolytic anemia, all of these. Okay. Organ failure can lead to cirrhosis, hepatic vein obstruction, portal vein obstruction, all of these. Metabolic disease can be Gaucher's disease, Niemann-Pick disease, Hurler syndrome, mucopolysaccharidosis, amyloidosis. Okay? All of these. Mild splenomegaly can lead to malaria, typhoid, disseminated TB, viral hepatitis. Moderate can be lymphoma, leukemia, cirrhosis. Severe can lead to Kala Azar, chronic malaria, portal hypertension, thalassemia major. So it depends on cause. Various investigations as per clinical features are being done. Treatment can be medical or surgical. Medical management involves treatment or cause of possible. Surgical is splenectomy, removing the spleen. Okay. There are various types of splenectomy techniques like open splenectomy technique, laparoscopy splenectomy, partial splenectomy. Complications that can arise can be pulmonary like left lower lobe atelectasis, pleural effusion, pneumonia, hemorrhagic, infectious like subphrenic abscess, wound infection, pancreatitis, pseudocyst, pancreatic fistula, thromboembolic. So, overwhelming post-plectomy infection can lead like loss of the ability to filter and phagocytose bacteria, loss of a significant source of antibody production. Source of infection can be streptococcus pneumoniae, others can be Haemophilus influenza type B or all of that. So, coming back to the question that we started with, what is the function of the spleen in the immune system? Is actually blood filtration and protection. We'll wait for a few minutes. If you have any doubts in this question, you can write in the chat box, ask me, and I'll wait for a few minutes break and then we'll go on to the next question for today. Okay, so moving to the next question for today. Which of the following is a fungal infectious disease? Okay. I'll repeat the question. Which of the following is a fungal infectious disease? Option A tuberculosis, option B influenza, option C candidiasis, option D cholera, option E dengue fever. So anybody would like to answer?
Option C.
Anybody else? Yes, you're right. Option C is a fungal infection, candidiasis. It's caused by the fungus mostly Candida albicans. Others are not fungal because tuberculosis is caused by bacteria, which is Mycobacterium tuberculosis. Influenza is a viral disease. Cholera is caused by bacterial Vibrio cholerae, and dengue fever we talked in the last question. It's caused by dengue virus, right? So correct answer is candidiasis. So for cholera, if we talk about cholera, it's a Vibrio cholerae. It's a comma shaped, curved and rod shaped bacteria of 2 to 4 micron long, motile by means of a polar flagellum. Colonies can be convex, smooth, round, opaque, and Vibrio cholerae and other vibrios, they grow well at 37 degrees and many different media. So they grow best on thiosulfate, citrate, bile, sucrose, agar, on which it produces yellow colonies that are readily visible against the dark green background of the agar, right? And they grow at a very high pH, like 8.5 to 9.5, and are readily killed by the acid. Therefore, infective dose is 50 is very high. Now, cholera growth characteristics Vibrio cholerae ferments both sucrose and mannose, oxidase positive. Most of the Vibrios are allotolerant, and sodium chloride often stimulates their growth. They grow on media which contains 6% NaCl. Therefore, alkaline water of pH 9 is with a very high salt is used as transport medium. Even sterile seawater is a good enough medium for transport and maintaining viability. Now it is a lipopolysaccharide that confer serological specificity. There are at least 139 O antigen groups, and the V cholerae strains of O group 1 and O group 139 cause classic cholera. Okay. Antibodies to the O antigen tend to protect laboratory animals against infection with Vibrio cholerae, and the Vibrio cholera serogroups O1 antigenous determinants that make possible further typing. Two biotypes of epidemic Vibrio cholera are classical and Evan-Tort. The Evan-Tort biotypes produces hemolysin, Eb positive and are resistant to polymyxin P. Vibrio cholerae O139 is very similar to Vibrio cholerae O1E1 for biotype. Vibrio cholerae O139 does not produce the O1 lipopolysaccharide but has polysac capsule, again unlike O1 biotype. Okay. So Vibrio cholerae and enterotoxin, they produce the heat level. Enterotoxin has two subunits A and B. Ganglioside GM1 receptor for subunit B, which promotes the entry of subunit A into the cell. Activation of subunit A increases the level of intercellular cyclic AMP and result in prolonged hypersecretion of water and electrolytes. Right? There is increased sodium dependent chloride secretion and absorption of sodium and chloride is inhibited, Diarrhea occurs with resulting dehydration, shock, acidosis, and death. Now, pathology is Vibrio cholerae is pathogenic only for the humans. Okay. The organism does not reach to the bloodstream but remains within the intestinal tract. So they attack the microvilli of the brush border of epithelial cells. There they multiply and liberate cholera toxin and perhaps mucinesis and endotoxin. Okay, I'll not go into this very much detail. So this is about candidiasis. Oropharyngeal and esophageal candidiasis are common. Okay. Uh, if you want to know more about in detail about Candida albicans and candidiasis, so basically I'll go to the slide. This is very much in detail. So Candida species have a worldwide distribution and are part of the microflora of the healthy digestive system of humans, animals and birds. And it's an opportunistic endogenous mycosis in that perturbance of the microflora or other debilitation of the host rather than exposure to an external source is the initiator of pathologic infection, right? So it's a fungus, it's a natural commensal of oral cavity, gastrointestinal tract and vagina, and it becomes pathogenic when host immunity is compromised. The morphology is very important. It's a dimorphic fungus, so yeast form like budding cells. It has hyphal, pseudohyphal form like invasive. It shows germ tube formation like diagnostic test and chlamydospores on cornmeal agar. The virulence factors can be ability to switch yeast like hyphae, adhesins for epithelial attachment, biofilm formation, secreted proteases, and phospholipases. The predisposing factors can be immunosuppression, like for in case of HIV/AIDS patient, chemotherapy patients, diabetes mellitus, pregnancy, prolonged antibiotic use, corticosteroids, indwelling catheters. Now, what are the types of candida infections? It can be mucocutaneous candidiasis, cutaneous candidiasis, invasive systemic candidiasis. So pathogenesis will basically be disruption of normal flora or immunity, overgrowth of candida, hyphal invasion of tissues and inflammatory response symptoms. Diagnosis can be microscopy like budding yeast and pseudohyphae, germ tube test, culture on suborau dextrose media. Okay. Treatment can be superficial treatments, infections like can be treated by nystatin, clotrimazole, fluconazole. Systematic infections can be echinocandins, amphotericin B, fluconazole, etc. Prevention will come from good oral and genital hygiene, controlled diabetes, rational antibiotic use, care of catheters in hospitalized patients, etc. Okay, so Candida albicans is the primary agent of thrush, although other Candida species have been isolated from both healthy and diseased birds. Clinical signs are not particularly characteristic. Affected chicks show unsatisfactory growth, stunted appearance, listlessness, and roughness of feathers. When candidiasis occurs as a secondary infection, the signs of the predisposing disease may predominate the clinical picture. Okay, and young birds are more susceptible than other older birds to mycosis of the digestive tract. Thus, as infected birds grow older, they tend to overcome the infection. Now, lesions occur most frequently in the crop and consist of thickening of the mucosa with whitish raised circular or rugose formations. Often there are curdy pseudomembranous necrotic patches that are peeled easily from the eroded mucosal surface. So the mouth and the esophagus may be diphtheritic and eroded. So clinical picture including poor hygiene or history of the long-term antimicrobial therapy is supported when candidiasis is suspected. Now, direct microscopic examination of fresh tissue samples is useful if pseudohyphae and budding yeast can be demonstrated. Treatment and control will be because mycosis of the digestive tract is apt to be related to unhygienic, unsanitary, and overcrowded conditions. They should not be allowed to exist or should be corrected. Lesions in the mouth can be treated by local application of a suitable antiseptic. And appearance of the disease in very young chicks suggests that the surface of the egg is a source of infection. Such a possibility could be removed by dipping eggs in a iodine preparation prior to incubation. So we already talked about cholera. Oh, we didn't talk about cholera, right? Sorry. We talked about. We did talk about cholera. We talked about Vibrio cholerae. Yeah. There's no need to go through it again. Yeah. We'll not go through cholera again. I'll upload this slides. So if you want, you can just go through the slides at your convenience. I'm not going to repeat the same in the class again. This is about cholera and the vaccines. So I said systemic candidiasis is the most common fungal infection in humans. It affects the skin, mucosa, various internal organs caused by candida. It can be candida albicans and non-candida albicans as well. So these are the non-albicans candida. It's worldwide in distribution. Candidiasis accounts for the most common fungal infection in humans, both in HIV and non-HIV infected patients. Extremes of age and pregnancy and low immunity, steroid or immunosuppressive drugs, post-transplantation, malignancy, all of these. Now, patients on broad spectrum antibiotics like diabetes mellitus, febrile neutropenia, all of these. Virulence factors can be adhesins like aspartyl proteinases and serine proteinases, helps in tissue invasion. Glycoprotein extracts of Candida albicans are pyrogenic. A pseudohyphae, presence of pseudohyphae indicates active infection. Phenotypic switching, ability to transform between phenotypic forms in the tissue, yeast and pseudohyphae. Invasive candidiasis, mucosal candidiasis, cutaneous candidiasis. Sample collection can be blood, sputum, urine, endotracheal, aspirate, pus swab, etc. Now, direct microscopy, gram-positive oval budding is cells with pseudohyphae. Okay, germ tube test, all of these are laboratory diagnosis of candida candidiasis. Not go into too much detail. So coming to the question that we started with, candidiasis is a fungal infectious disease. I'll wait for a few minutes. If you have any doubts, you can ask me. Then I'll move on to the last question for today. I'll take a break for 2-3 minutes. Okay, so we'll move on to the last question for today. Which experimental approach proved that serum from animals exposed to toxins could protect other animals? A. Phagocytosis studies by Mechnikov. B. Serum therapy experiments by Behring. C. Toxin neutralization by Ehrlich. D. Discovery of complement by Bordet. And E. Agglutination studies by Gruber and Derham. Anybody would like to answer? Anybody would like to answer? I'll wait for a few minutes. Okay. Anybody would like to answer? Okay, so we'll talk about all the studies in short. So Mechnikov's phagocytosis studies basically talked about cell-mediated immunity, right? So the scientist was Eli Mechnikov. Experimental model was starfish larva, water fleas or daphnia, and the key experiment was they inserted foreign bodies or rose thorns into the starfish larva. Observed mobile cells migrating toward and engulfing the foreign material. So the observation is that certain cells actively ingested and destroyed microbes or foreign particles. And they concluded that immunity can be mediated by cells, not just soluble factors. So, discovery of phagocytes by macrophages and neutrophils. Significance is foundation of innate immunity, introduce the concept of cell-mediated defense. Next is Behring serum therapy experiments, which talks about humoral immunity. So, scientists Emil von Behring and Shibasaburo Kitasato. Experimental model was guinea pigs or rabbits, also diphtheria and tetanus toxins. So the key experiment was animals were immunized with inactivated toxin. Serum was collected from the immunized in animals. Serum transferred to non-immunized animals. Recipient animals survived toxin challenge. The observation was that protection was present in the serum, not the cells. Conclusion was blood contains soluble protective factors or antibodies. Established passive immunity. Significance is the first proof of humoral immunity basis of antitoxin therapy. Behring won the first Nobel Prize in medicine. Then Ehrlich's toxin neutralization and side chain theory. scientist Paul Ehrlich. The key concept was side chain theory, a receptor theory. Cells have specific receptors or side chains that bind toxins. Binding triggers overproduction of receptors. Excess receptors are released into blood as antibodies. Now, it showed quantitative neutralization of toxin by antitoxin. Neutralization followed specific chemical ratios. So, they concluded that antigen antibody interaction is highly specific and antibodies neutralize toxins by direct binding. Significance was explain antibody specificity, introduce concept of receptors and clonal expansion, foundation of modern immunochemistry. Then we have Bordet's discovery of complement system. Scientist was Jules Bordet. The key experiment was studied antibody-mediated lysis of bacteria, heated immune serum, lost bactericidal activity, added fresh normal serum, the activity was restored. The observation was two components needed: heat stable component antibody, heat labile component complement. Conclusion was antibodies alone are insufficient. A serum factor or complement is essential for lysis. Significance is that discovery of complement system explained bacterial lysis, hemolysis. That's a key link between innate and adaptive immunity. Then we talk about Gruber and Durham's agglutination studies. Scientists Max Gruber and Herbert Durham. The key experiment was mixed bacteria with immune serum, observed visible clumping or agglutination. Observation was agglutination was specific, only occurred when a correct antibody met its antigen. Conclusion was antibodies can cause cross-linking of particular antigens. Significance was it's the basis of viral test, blood grouping and serological diagnostics. Right? So the correct answer here will be serum therapy experiments by Behring. Okay. I'll talk a little bit about ELISA. Not I'll talk about in detail in the next class, but what I'll talk about ELISA here was that Emil von Behring from Germany and Shiba Shuro Kitasato from Japan noticed an antitoxin formed in the blood of animals infected with diphtheria bacillus. When antitoxin serum was transferred to an animal given a lethal dose of toxin, the animal survived. So they proposed the humoral theory of immunity based on the toxin antitoxin theory. Right? So, in 1901, Emil von Behring was awarded the first Nobel Prize in Physiology and Medicine for his work on serum therapy, especially his application against diphtheria. It is unclear why Shibashuro Kinosato was not recognized. Okay. We'll talk about these in the other class, but I will talk about more about Behring now. So, while with the world in the grip of COVID-19 pandemic, researchers are working, like we know, at unprecedented speed and levels of collaboration to develop a vaccine for the disease. That was what was happening during the pandemic. So, while we await the fruits of that labor, other medical scientists are also working on a serum therapy that hope they can help reduce the severity of the illness and hasten the recovery of COVID-19. So we know that vaccines stimulate the body to produce its own immunity to a specific disease. But serum therapy takes disease-fighting chemicals like antibodies from the blood of recovered patients and transfers them to the sick to boost their defenses. For the therapy to work for COVID-19 patients, researchers must show that those who recover from the disease gain a lasting resistance to the virus that causes it. Such resistance to reinfection commonly occurs after many viral and bacterial illnesses. But it's yet to be confirmed whether this holds true for the new coronavirus. If confirmed, this approach, often referred to as convalescent plasma therapy, would save lives and reduce the number of new infections during the year or more needed to test and roll out a new vaccine. Okay. So, the first Nobel Prizes were awarded in 1901. German physiologist Emil von Behring received one for his work both in showing serum therapy could be used as a general technique to fight infectious diseases and in being the first to use it on a patient. So, the Nobel Committee observed that he had opened a new road in the domain of medical sciences and thereby placed in the hands of the physician a victorious weapon against illnesses and deaths. Okay, so basically, he was among the doctors who, in the early 1990s, pioneered serum therapy to combat the heartbreaking scourge of diphtheria, which killed up to half of the children taken by it. Injected serum reduced the mortality rate to 15%, sometimes working like a medical miracle. Children who had been gasping for breath and were near death could be breathing normally within a few hours. So, newspapers in Europe and the United States trumpeted the success of this antitoxin, generating widespread public enthusiasm for a novel lab creation. So, concepts we take for granted such as antigens and antibodies did not yet exist. So, von Behring and his French competitors like Emile Roux and Alexander Yersin knew only that some chemicals found in the blood of recovered patients acted against the bacterium that causes diphtheria. So this antitoxin remained after blood cells were removed, leaving the blood serum behind. When this serum was injected into an infected patient, it strengthened the body's ability to fight the disease. Now, scientists at the Pasteur Institute in Paris quickly scaled up their blood collecting techniques, realizing that the scant pint of serum they could get from a single patient's blood wouldn't add up quickly enough. So, they began injecting docile horses with increasing doses of diphtheria toxin, effectively immunizing them and turning them into blood serum factories with a single product, immunity. How fascinating this is for if you think the time at the times when nothing was known. The diphtheria breakthrough and the introduction of the serum therapy for tetanus opened up a whole new world of biological remedies, products created in the laboratory by living creatures distinct from the old world of chemical and botanical drugs. So serum therapy for pneumonia was a revelation when it appeared in the 1930s, and it saved thousands of lives before being replaced by penicillin, another biological product in the 1940s. So, in time, vaccines for diphtheria and pneumonia displaced the need for more cumbersome serum therapy. Okay. So, treatment of diphtheria was based directly on work by Roux and Versin. They had isolated a filtrate from diphtheria cultures that caused symptoms of the disease were injected into guinea pigs, rabbits, and pigeons. This showed that diphtheria was not caused directly by the infection with the bacteria but by the toxins they produced. So in 1890, von Behring and Kitasato found that the low doses of diphtheria toxin modified by heat and injected into rats, mice or rabbits appeared to protect them from the illness. They realized that the body produces antitoxins when exposed to low doses of the toxin, and these protect against full exposure to the disease. And the antitoxins neutralize the poisons and create resistance. The blood serum of animals with resistance to diphtheria toxin continued to protect against the disease when injected into another individual. Similar techniques were used to develop an antitoxin for tetanus. So, in years to come, this immunity became the founding principle of immunology. So, the modified toxin caused severe reactions in humans and could not be used as a vaccine, but the antitoxin from immunized animals protected humans from the disease. So, diphtheria antitoxin was first produced on large scale from horse immune serum in 1896. Okay, so you can go, if you want to know more about this, you can go back and read this paper. You can go back and read this paper. This was about Emil von Behring and serum therapy. You can just go back and type this and it will come on your system. You can go back and you should read this paper. So coming back to the question for today, which experimental approach proved that serum from animals exposed to toxins could protect other animals? The answer would be serum therapy experiments by Behring. Okay. I'll wait for a few minutes. If anyone has any doubt, you can ask me. Okay, so if you have no questions, we can stop the session for today and we'll meet again next Monday. Thank you. Thank you everyone.